Welcome to the Jack Westin MCAT Podcast with your host, Phil Hawkins.
And Azaii Calderón Muñiz.
All right, guys, take a deep breath. We're going to be talking about breathing today. I'm super excited. You can breathe out, by the way, if you've been holding it. I'm not going to tell you every time to breathe in and breathe out over today's episode, but we are going to talk about the respiratory system. And I am super amped because I love physics and I love chemistry, perhaps more than anything else in the world. And respiratory is I feel like one of the most physics and chemistry oriented, physiology sections that I've dealt with for the MCAT and also in med school. I really feel like if I had continued with the med school path, I'd probably be a pulmonologist because it's just the most interesting thing to me in terms of pressures and volumes and fluid dynamics and acid-base pH stuff. Now, because of all of that, I want to point out that there are a lot of connections to fluid dynamics, to pressures, to ideal gas laws, to pH stuff, which may seem confusing at first, but I promise that'll be clear here in a little bit. As a result, I think that pulmonology is one of those areas, and just like the respiratory system is one of those areas that is very likely to show up not just in the bio section, but also in the chemistry and physics section, because it's so easy to tie it to other things in the chemistry and physics topics. I also want to remind you guys, I'm sure you know, but even in the chem phys section, there's a lot of biology in that section of the test, just like there's biology in the psych soc, and just like there's some chemistry, some in the biology section of the test. Things are a little bit muddy. I feel like the names of the sections don't actually tell you what's in them, just what you're going to see more of in that section. And so as a result, this is one of those things I think you're likely to see in the bio section and in the chem phys section. So about half the exam, I think you could see respiratory stuff kind of anywhere in there. And so I'm super excited to dive into it for that and for other reasons.
I think it's good to dive into this. Breathing is important.
Yeah.
And so, you don't need to take another deep breath, but we do need to talk about how you breathe, right? Because this is something that was a little mind-blowing personally when I actually learned how this works. Because you think, okay, yep, deep breath in and deep breath out, and that's it, right? But there's actually a lot of complex signaling that goes on. We won't go into the complex signaling. We will focus more on your favorite, the physics component of it. But I do want, folks to recognize there's a lot of sensing that goes on at the level of the brain, but also the immediate area, and within the lungs, your body's going to sense the level of carbon dioxide, right? Decide if it needs to increase breathing rate or decrease it, et cetera, when to take a deep breath in versus not. But what about how we actually take a deep breath in? So first, let's back up and think, okay, what's the difference between positive pressure and negative pressure, right? So if you imagine a vacuum, okay, we can all agree that the vacuum is pulling something in and it's suctioning. And so we have this this is akin to negative pressure where it's going to suck in, right? Positive pressure, imagine pushing on a water bottle. And so you are exerting a positive pressure on that water bottle. And so it is moving in response to your pressure. So both can cause movement, and they're going to cause movements in opposite directions, right? Positive pressure is going to cause movement away from the direction of the pressure or the force that is applying. And the negative pressure is going to cause movement towards it, right? So two important things to keep in mind. Now, when you're breathing, the atmosphere, when you're taking a deep breath in, the atmosphere is producing a positive pressure, right? You should know the different units of pressure for the physics component for sure. But again, you could theoretically see it on the biochem section as well. But there's actually parts of your lung that are going to have a negative pressure. And so you have your actual lung parenchyma, right? The tissue, but you also have this space around your lungs, and your lungs are surrounded by what's called the pleura. And so it's going to make sure that the tissue of your lungs don't rub up against directly, or don't directly rub up against your ribs and everything else that's in there, right? Because that would be really problematic if your ribs and your bones were just shaving away at your lungs. So this pleura provides kind of that lubrication and allows for that, but it's also going to allow for this development of negative pressure. And so the combination of the positive pressure from the atmosphere and the negative pressure surrounding your lungs are going to allow for lung expansion, right? And chest expansion. And so that's going to allow for air to come in and for you to take a breath in. However, now there's all this pressure inside your lungs, right? And your lungs have this tendency to recoil and snap back. It's like a balloon, right? You can only expand it so far before it wants to snap back in. Mm-hmm. And so that plus the muscles having been stretched, right? That combination of lungs expanded, muscles stretched, all that good stuff, this change in the pressure is going to cause your lungs to collapse and you're going to breathe out.
Yeah. This is so physicsy. I love it. Like I have a hard time. Like I want to talk about all the physics awesomeness that's going on here. No matter what, air moves from higher pressure to lower pressure, or like all fluids, they move from higher pressure to lower pressure, right? Like if you squeeze a water balloon, the water will squeeze. I mean, it's already squeezing. If there's a hole in it, water's going to come out of it. And so, but that's because there's higher pressure inside. And so this is for all fluids. This is actually related to Poiseuille's law, which is a fluids equation that one day we'll like get into the physics and chemistry section. We did the psych, we did the bio. We're going to get to physics eventually, but we kind of get a little physics day in here. So this change in pressure. So like going back to the vacuum thing, when you turn on the vacuum, it's negative, like it lowers the pressure inside the vacuum. So that pulls air in because it's higher pressure outside, lower pressure inside. You could also turn off the vacuum. This probably isn't very clean, but you could take the hose and you could just blow into it, right? Like that also would get air to go into the vacuum.
No, thank you.
Yeah, but in that case, what you're doing is you're creating a higher pressure, both your like lungs and squeezing and shoving the air into that vacuum. And so there's two ways to get air into that vacuum. You can lower the pressure inside, so it's higher outside than it is inside, so it comes in, or you could raise the pressure outside, so it's higher pressure outside than it is inside. So that's what we talk about when we talk about like positive and negative pressure. Basically, it's like, are you raising the pressure to get air to move, or are you lowering pressure to get air to move? And you could do either to get air to go into that vacuum, right? And so the way that we breathe when we're inhaling is a negative pressure system, because what happens is like the muscles between our ribs contract. That's the word I'm looking for. Contract. And that actually pulls open your ribs, right? It's like if you had like a Ziploc bag with a straw in it and you grabbed the edges of the Ziploc bag and you pulled the bag apart, right? Air is going to get sucked into that case because we're creating a vacuum in there whenever we pull the pages apart. So that's what's happening when we breathe. Every time we breathe in, it's negative pressure because we're like our ribs are like opening up, and that's like kind of like just like pulling apart the sides of a Ziploc bag that pulls air in. And that's a really important thing to understand, that difference between the positive and negative pressure systems and being able to relate that to the MCAT.
Yeah. And this is, and just because we love making connections, a couple of quick things. So this change in pressure, you can also see it, and they might start asking about ideal gas law. This is another connection point that is fair game on the MCAT if you get a passage that is associated with lungs or the respiratory system, but also with muscle contraction, chest expansion, right? Muscle contraction, musculoskeletal system, fair game associated with this topic as well. Now, what's really cool is we know how we breathe, right? And we can actually do something about it when folks stop breathing. And so there are actually a couple of different ways, but I just kind of want to talk about a few. And these are just more fun. And theoretically, the MCAT could choose a passage on one of these topics because it's going to relate to the respiratory system. Doesn't mean it's a guarantee that you'll see it, right? So there are a couple of ways. Really, really long time ago, we developed, not we, but folks developed what's called the iron lung. And essentially, it's this giant tube, an apparatus where you are encased by basically this iron tube and your head sticks out through the top.
Mm-hmm.
And so at the base of this iron tube, there's what's called this diaphragm, and it's going to mimic what your diaphragm does, which is push up when you are exhaling and expand and come down when you're inhaling. How to think about that for a second. Yeah. And so this diaphragm is going to push in and pull out, and it's essentially going to create this pressure differential, and it's going to breathe for the person, and it's actually going to cause their chest to expand and then contract to breathe for the person. This is when someone has lost the ability to breathe for themselves. There's actually this TV show that I was watching, and I wish I could remember the name. This was a couple of weeks ago, but they had someone who was in an iron lung.
Was it like an older guy in Texas, like a lawyer? Because
an accountant?
Maybe, yeah, an accountant, right? Yeah. Like there's a guy in Texas I know of who is still in an iron lung, and like iron lungs are not that common now. Like they used to be way more common back in the day, but that's mostly because of polio. And so like there are people who needed to be on, like they needed help breathing for like their entire life. And I think this guy had polio. And so
in the show, he also, I think, had polio, but I don't think they specified if he was from Texas, but it wasn't a documentary. It was like just a regular TV show. I'm not much of a documentary person. Man, I wish I knew which one it was. But anyway, yes. So I saw that. I was like, oh, an iron lung. But like you said, they're not particularly common because we have better ways to help folks when they don't need this kind of continuous support. And so let's say that, someone's down and they needed CPR and their heart and lungs are no longer working. You can breathe for them, right? When you're giving them CPR. And that's why in the past, they used to do chest compressions, breath, etc. What they do when they're taking them to the hospital, what you'll notice is one person doing the chest compressions and someone else with a little baggie that has a seal around their mouth, and someone's just pushing the bag, letting go, pushing the bag, letting go. When you guys are in the OR, in the operating room, and you watch the anesthesiologists, before the anesthesiologist intubates someone to breathe for them, they will actually use a bag. And just to make sure that the person is getting air, and then they'll go intubate them and then they'll reconnect them. And so what they're doing in that case with these bag ventilators is that they are producing more pressure so that the air has to go in. And so that's another way to breathe for someone for shorter periods of time. Now, you could actually breathe for someone theoretically indefinitely. That way, you're just going to get really tired and you're not going to be able to do it effectively. But what's really interesting is that the lungs can only handle so much pressure, right? Because they're tissue, and these tiny alveoli that you have, they can only handle so much pressure, right?
Right.
So you actually have to be really careful when you're working with an anesthesiologist and you're actually providing the breath for the person. You actually can't push too hard, you can't push too hard and too quickly, because you have to give the lungs a chance to expand and a chance to contract. Now, I don't think we had planned on talking about this, but there is always a little bit of air left in your lungs. Otherwise, your lungs would collapse. Okay. These different mechanisms will also make sure that there is always just enough positive pressure so that your lungs don't collapse. That takes us kind of to the third one, which is a CPAP machine. And it's a constant pressure source that is going to breathe for someone at night. And this is going to be for someone that either, has obstructive sleep apnea and it's really bad, and that's just that they can't breathe secondary to a mechanical problem on their own, versus, central sleep apnea and their brain is not sending the signal to breathe, which is really problematic because you can't live with it without some help, right? Yeah. And so in this case, there's this constant positive pressure that's going to be just enough to keep the lungs open, but also help the person breathe throughout the night. Otherwise, again, the lungs would collapse, and we don't want that. So we're going to keep the lungs open. There are all these different ways then that you can help breathe for someone. And so, you want to make sure that, as there are actually a lot of medical conditions that will decrease the strength of the muscles with time and cause deterioration and the inability to breathe effectively. And so these are all things that, push comes to shove, can be used, right? But you want to keep in mind that you always want to pay attention to someone's ability to breathe. And that's why when you're in an emergency situation and they tell you, the ABCs of stabilizing someone, airway.
Yeah.
Airway, you have to stabilize that airway. You have to make sure someone can breathe. And so knowing how people breathe and what you can do, super helpful.
Yeah. It's just really interesting. And I know I nerd out more on the physics of this, but that's why I love the lungs. But like identifying, is this the CPAP machine, the bag ventilator, the iron lung, which ones are positive pressure and which ones are negative pressure? And the thing with the iron lung is essentially you're in this can that just creates a vacuum every once in a while, and that pulls your ribs open. And so that lowers the pressure inside your lungs, just like we normally breathe. Right? We normally breathe through this negative pressure system of like creating a vacuum that pulls air into our lungs. The bag ventilator, where you put the bag, or CPR, where you're blowing into somebody's mouth, right? Either by squeezing a bag and shoving the air in, or breathing in with your actual air from your lungs. That's going to be positive. I think CPAP stands for continuous positive airway pressure. I think that's what it stands for. Yes. So those are both going to be more positive pressure systems. Mm-hmm. Our body works most of the time through negative pressure. And so actually, like in terms of like long-term stuff, it's better for your lungs to use a negative pressure system. So like if somebody needed to have help breathing for like a year, if you had somebody on like a positive pressure system, that might damage their lungs and like cause issues where they're going to have a hard time getting off of that ventilator because their lungs are damaged and they have like a harder time with that, versus a negative pressure system. They're more likely to, that's much better for long term. Now, as we mentioned, like that means that technically the iron lung is a much better long-term thing than like a bag ventilator, right? Which we see way more bag ventilators these days, but that's because of a couple of things. One is like an economic thing, like a piece of plastic, like a bag is way cheaper than building a giant, like heavy machinery iron lung thing, right? Which is basically like putting like an entire body except for the head in a giant steel can that's airtight and got machinery attached to it. But the other thing is that we kind of just don't have a lot of people that need help breathing like long term. We used to have a lot back in the day because of polio. I know we talked about polio last episode too. I'm like, we're not trying to talk about polio. It just keeps coming up. But this caused a lot of people who had like paralysis, partial or complete, of like the diaphragm. And so they needed to be on a ventilator for like 50 years. Right. And so an iron lung is way better in that case. But now, we've eradicated polio essentially. And so we don't really need iron lungs around, like, even though they were kind of better for certain scenarios. So it can be really hard to find an iron lung, especially because I think we like melted some down for like war and machinery stuff, like during, I think, World War II. But like understanding that, so there are still a couple of people in the US who had polio and have this paralysis and who are still using iron lungs to this day. And it's just kind of an interesting thing because it can be hard to find an iron lung at this point, just like around the US.
Yeah. And I know some folks might be thinking, okay, but there are tons of people who have trouble breathing on a regular basis and who need things like inhalers all the time.
COVID
and why? Yeah, exactly. And so why don't they need an iron lung? And you want to think about the mechanism here, right? This is an issue of muscle contraction, right? Or the diaphragm not being able to contract and relax and doing its job, versus maybe the tissue is irritated, right? Or very reactive, as in the case of reactive airway disease. Those are two very different things. The folks who have this irritated lung tissue or the damaged lung tissue, they're still able to go through the mechanism, right? The mechanics of breathing in and out. Whereas the folks who their muscles are losing their ability to contract and relax, who are paralyzed, those particular muscles are paralyzed, or that, their diaphragm is out for the count. Their body cannot go through the mechanics of breathing in and out. And so those are two very distinct processes. The folks who need, inhalers or who have things like, COPD or asthma or things like that, they can still go through the mechanics. So they're not going to need an iron lung or that continuous support. And then there are folks who are on continuous oxygen, but that's a perfusion issue, right? And the movement of oxygen and getting enough in rather than not being able to mechanically breathe. So when we say, oh, they can't breathe, there are two different processes that we're thinking about, and therefore there are different solutions for those processes. So we just have less people that can't mechanically breathe and that just need shorter term support, or who have, trouble with perfusion or the actual lung tissue itself.
Yeah. And exactly. I think like the short term, long term also plays just such a big role in that, where like being on a positive pressure system for like an hour or a day or a week or like even several weeks is probably not going to create a problem at all.
Yeah. Not going to be fun. But not
yeah, it's not going to be fun, but it's not going to cause like long-term permanent issues. It's when you start dealing with like 6 months, a year, 2 years, like all of a sudden, like, ooh, like it'd be really nice to have a negative pressure system in that case, but we don't need that often these days. And so it's kind of an interesting thing overall. But you also talked about that like issue of perfusion, right? Because like why we are breathing is to like one of the reasons is to get oxygen to our tissues. I know everyone thinks that that's the only reason. We're going to talk about some other reasons that we breathe, but we need to get like oxygen to my neurons, to my muscles, to like my intestines, to like, like my, like all the cells in my body. The vast majority of them need oxygen to survive. Red blood cells are kind of an exception to that. They actually don't need oxygen, which is important because they're the delivery men for oxygen. They don't have mitochondria, so they actually can't burn oxygen through like the electron transport chain, which I think is something the MCAT likes to test. So just fun fact there, like red blood cells can't use oxygen. And that's by I about said by design, but like that's really an important critical design of erythrocytes, red blood cells, because if they could burn oxygen and it was their job to carry oxygen, they're going to burn the oxygen they're carrying. I always like to use the analogy with red blood cells as like pizza delivery men. Like if they were hungry and ate pizza, that would be bad for me, like for them to deliver me a pizza, right? I need them to bring me the pizza and not eat it on the way. But talking about this kind of delivery system, it kind of creates this tricky, intricate balance that we need, right? Like in terms of like down at the enzymatic level, we need something like at like a subcellular, we need our hemoglobin to grab oxygen so that we can deliver it. And so we need it to have affinity for oxygen, but we don't want it to have too much affinity because then it won't let go, right? And so I need it to be kind of sticky to oxygen, that it will grab oxygen, but not so sticky that it will hold on to it forever. And so there's this balance, like once again, kind of like this push-pull sort of thing going on. We need it to grab, but not too well, right? And this is, I think, one of the trickier things for people to understand, because like at first glance, everyone thinks like, oh, we need our hemoglobin to just grab all the oxygen all the time. And if our hemoglobin had such high affinity for oxygen that it grabbed all the oxygen all the time, it would never let go of it. And so in your lungs, when you breathe in, right, and air goes into your lungs and the red blood cells go by and the alveoli and they run into that oxygen, not all of the hemoglobin is going to grab the oxygen. Something like 97, 98% is going to grab the oxygen. And so there's some hemoglobin that won't grab oxygen even when it goes to the lungs and goes around your body. And it needs to be that way. We could raise the affinity and make it better at binding, but then it's going to be way worse at letting go. And I need it to let go. So like in a cycle going through my body, like 97% of my hemoglobin is going to grab oxygen in the lungs. And then when it goes to the tissue, like 30% is going to keep a hold of that hemoglobin and it's not, or keep a hold of that oxygen and it's not going to let go. Right. And so if you think about this in terms of like the pizza delivery, like guy kind of like sort of scenario, like if I ordered 100 pizzas from 100 different pizza delivery places, and that's obviously my hemoglobin, what's going to happen is 3 of those pizza delivery guys are not going to pick up the pizza, and they're going to drive to my house without the pizza, right? And so like 97% of our hemoglobin grabs oxygen in the lungs, the other 3% doesn't. And then it goes to the muscles, and then it gets to the muscle. And it's like, oh, sorry, forgot to grab the oxygen. And so I forgot to bring the pizza. But then like 30% or 30 of those pizza delivery guys are going to drive to my house with the pizza, and then they're going to drive off with the pizza. And so they're going to keep the pizza in that case, like as they kind of drive away. And so that's kind of what's happening in our muscles, where like 30% of our hemoglobin gets to our muscle and is like, they're binding the oxygen so well that they won't let go. And so they'll hold on to that and then go back to the lungs. And so in one like cycle of this, like 3% didn't pick up oxygen, 30% didn't drop it off. It means 33% of those things that were coming to me to like deliver pizza or deliver oxygen, however the analogy is breaking down, they didn't deliver anything actually, which means only about 67, somewhere around there. And I want to be clear, these numbers depend a lot on what's going on in your tissues, like the pH, like how oxygen deprived the tissue is, like the oxygen content of the air that we're breathing in. So don't say, like Phil said, these are the numbers, because those numbers can change drastically depending on if you're climbing a mountain or if you're breathing like pure oxygen. Just to kind of like hit that one other idea there, like of the amount of oxygen in the air, because this is also something the MCAT likes to test in like chemistry of like the partial pressures of oxygen and stuff like that. Every time we breathe in, like the air that we're breathing in is not mostly oxygen. It's only about like 20% oxygen, right? 21% versus the air that we breathe. Most of that is actually nitrogen into gas. Those of you who are thinking about chemistry know that nitrogen and nitrogen are triple bonded to each other when you have nitrogen gas. And because of that triple bond, it's super stable and doesn't really react with anything. And so like the nitrogen in the air, even though that's 70% of the air, doesn't really do anything. And so like being in that sort of scenario where like only 20% of the air is actually oxygen, the rest is like carbon dioxide and other stuff. Those of you who are checking the math, you're like, wait a minute, 70 and 20, there's more. That doesn't add up. Like there's other stuff in the air, but like it's 5% carbon dioxide and everything else is just like random small things. But that's important as well. Like understanding like what's going on with that. So if somebody is having trouble getting enough oxygen to tissue, one thing you can do is just get them more oxygen into the lungs. And so maybe bump that like 97% that's grabbing oxygen to 100%, right? And like getting more hemoglobin actually grabbing onto oxygen by just increasing the amount of oxygen in the area.
Phil, you made me really want pizza today. Which is a problem because I have like 3 pizzerias within maybe a 2-3 block radius.
Oh, you're lucky.
So if folks want to send us here at Jack Westin some pizza, 100 pizza delivery guys, I won't complain.
Right. We'll see if they can beat hemoglobin.
Let's see if they can beat hemoglobin. No, but there's a lot really here. And I think something that you brought up, giving people oxygen, I think it's really important to understand, similar to how we said, okay, is it a tissue issue versus a mechanical ventilation issue? That's going to help you figure out, for example, when a baby is born, let's say the baby is blue, right? You can figure out if the problem is actually in the lungs or not by giving them oxygen, right? Mm-hmm. However, if they have, and this is a really cool kind of random case, if you want to look into it, you can. You're not going to get tested on it on the MCAT, but there are cases where the aorta and the pulmonary artery get swapped. And so it is basically a closed circuit where the same blood is getting recycled within the lungs, but that oxygenated blood is not getting sent anywhere else in the body. And so in that case, you can give the child oxygen all you want. It's not going to do anything, right? Because the lungs are getting plenty of oxygen. So you're just whisking them off to surgery. And so this is just another way that theoretically, they could give you a passage on, transposition of the great arteries, right, in little kids. And they could test you on all things respiratory. And you'd be expected to know the respiratory component, not the genetic or not the congenital illness, right? So just thinking about that, don't freak out if they give you something wild like that. Now, you mentioned hemoglobin needing this this balanced affinity for oxygen, and it being able to bind different amounts based on how much oxygen there is. And it's also going to be able to bind different amounts or different molecules, different numbers of molecules of oxygen based on how many are actually already bound. And so a protein's ability to bind multiple units, and having one unit change its affinity for binding other units is called cooperative binding. And so often we think about it in the context of hemoglobin. Oh, the first oxygen binds. It's easier for the second and the third oxygen to bind. And that's positive cooperative binding. What's really cool, though, is that there are cases where one binds, the others are less likely to bind. So I had to look this up. But CTP synthetase is apparently an example of this kind of negative cooperative binding. And so one way that they can toss this at you is what's called Hill's coefficient. And so if it's greater than 1, right, positive, oh, it wants to bind more, right? So that first unit binding is going to make the other units more likely to bind. Whereas if it's less than 1, it's negative, so it doesn't want to keep binding. And if it's equal to 1, it doesn't care what's already bound, right? So it's not cooperative. Now, what's also really interesting is we've talked about hemoglobin. Some of you might be thinking, well, I've also heard of myoglobin, right? And so with myoglobin, what's interesting is that it only has one heme, right? So it's only going to bind one oxygen. So it's not going to be cooperative, but it needs that oxygen because it's working at the level of the muscles. And when the muscles are super active, they're going to consume a lot of oxygen, right? When you're running, your muscles are like, send me all the oxygen. I need help for aerobic respiration, which is something else that they can test you on in relation to a respiratory system passage.
Yeah.
And so in this case, it needs to grab as much oxygen as it can. And yeah, it's going to be able to deliver it in that case because the muscles have a lower amount of oxygen in them than other tissue. So this is where you have different types of molecules binding to oxygen, different ways of interacting and different amounts of binding, and how that propensity to binding will be affected by the environment.
Right, exactly. And just to be, so my hemoglobin, which is in our blood, generally grabs 4 oxygen, actually oxygen dimers, O2. So it'll bind O2. And I really like that, like cooperative binding and like understanding like the positive versus negative, because that's something that is really, the MCAT loves to test that. I always like to use the analogy of like, let's imagine you had 4 little kids that you were babysitting and you gave one of them ice cream. Like the other ones need ice cream now. Like you can't, like giving one of them ice cream makes the rest of them want ice cream way more, right? And like if you didn't give any of them ice cream, it's fine. But if you give one of them ice cream, like you better have 3 more ice cream cones. And it's kind of the same thing with hemoglobin, which is these 4 subunits. And as soon as one of them grabs oxygen, the other ones like really want oxygen and they really like want to grab it. Just in terms of like graphing that, like whenever you graph like the oxygen's or hemoglobin's affinity for oxygen, because of that cooperative binding, instead of being the normal just like swoop, it's like an S-shaped thing. We call that a sigmoidal curve. So if you ever see a sigmoidal curve, you need to, like in terms of like an enzyme's activity, you need to immediately think, hey, that's a cooperative system, generally positive cooperativity. Now, like, so that's something you really want to make sure that you understand. And that actually helps oxygen picking up, or helps hemoglobin picking up oxygen and letting go of it, right? Because like once oxygen starts to fall off, the other ones start to fall off. And once one gets it, the other ones start to get it. And it is kind of an interesting thing, understanding how all of that goes together. I also love like talking about myoglobin, just in case somebody, like a quick Latin lesson, myo means muscle. So if you hear myocyte, right, like that sort of thing, like a cardiomyocyte, that's a cardio, heart, myo, muscle, cyte, cell. So heart muscle cell, cardiomyocyte. So myoglobin, if you hear somebody's say they got a myeloma, that's like a tumor or muscle based. So myoglobin is kind of like hemoglobin, only it's just found in muscles. And myoglobin is actually that kind of case of something that's got really high affinity. Like it grabs oxygen and it really doesn't want to let go. It grabs oxygen. And so most of the time in your body, your myoglobin is not giving your muscles oxygen. If there's oxygen around from like hemoglobin delivering oxygen, it'll grab it and then just hold it, and it won't let go. It'll only let go if your muscle is completely devoid of oxygen. Then it'll like start to let go of that oxygen. So you can think about it as like an oxygen reserve, right? And so this is why like you can like start running, like sprinting, and you're burning oxygen faster than you're bringing it in. And so you can start sprinting, and your myocyte or your myoglobin is going to start giving you a little bit of oxygen, but eventually you burn that. And so you don't have any more oxygen. You're not getting enough oxygen to your tissues. Like you use that extra reserve. And so that's one of the reasons you can't keep sprinting, right? Like you can't keep up a sprint for a mile, because that's not how sprinting works. Like your ability to run diminishes after a certain amount of time because you have burnt up that oxygen, which is kind of interesting. And so kind of understanding that is big, that like affinity for oxygen. Something that's got higher affinity is going to grab, and it's going to have a harder time letting go. To take a second and kind of talk about, like, you know, I know you talked about like, you know, a kid being born who's blue, right? And we're going to assume it's not a Smurf, or somebody who has a bunch of silver, which can also turn your skin blue. That's a really interesting thing. If anybody wants to Google that, totally not testable for the MCAT, but like people who there was a guy in Tennessee, I think, who drank colloidal silver, and he became like, I don't mean like bluish. I mean, he was like blue, like he looks like a Smurf. I feel like that sounds offensive, but like, no, he's just as blue as a Smurf.
He would have stopped at some point.
Yeah, it's super interesting because he's got silver deposits in his skin. But assuming it's not one of those things, they're not getting enough oxygen. And so while talking about fetal stuff, like before a fetus is born, it's really interesting because they need oxygen for their tissues to work, for their heart to beat, right? For their ability to grow, just like you need oxygen to grow. And so their source, they can't just breathe in oxygen from the outside because it's not open to the outside. So they need to be able to steal oxygen from the mom. And so the hemoglobin of a fetus is different than the hemoglobin of an adult. And actually, the fetal hemoglobin has higher affinity for oxygen. So it will take oxygen from the mom's blood. Now, that fetal hemoglobin is actually worse at delivering it inside the fetus than like regular adult hemoglobin is good at delivering, right? And so it's even a little bit worse there, but it needs to be higher affinity in order to grab the oxygen from the maternal hemoglobin. It's really interesting. There's a lot of things that change and like a baby after it's born, but just kind of like the actual blood changes. Like the hemoglobin goes from a fetal hemoglobin to an adult hemoglobin, and that actually like changes things overall. So the affinities are different in like fetus versus adult.
Yeah, there are actually illnesses of, you know, that adults get or that adolescents get, like sickle cell, that their adult version, yeah, the thalassemias as well. Their adult version of hemoglobin is problematic, right? And it's not effective, or it's going to, in sickle cell disease, right, sickle and cause a lot of damage and pain crises. And so we actually try and have these people we try and induce their body to produce more fetal hemoglobin and kind of work their way backwards so that they don't have their hemoglobin injuring, you know, the vasculature in their tissues. But I kind of want to pause and recap really quickly because I know we've talked about a lot so far. And so, you know, this is a chance to kind of check yourself and say, okay, what have we covered? What do I need to make sure that I can repeat back or teach back afterwards? So we've talked about the mechanics of how we breathe, right? We've talked about the negative and positive pressure. We've talked about the iron lung, but the difference in pressure gradients. Remember that you can get tested on the ideal gas law and also partial pressures. We've talked about the affinity of both hemoglobin and myoglobin to oxygen. We've also talked about something that's higher affinity will grab, but not release unless it's in a relatively, depleted scenario. So if you're running from a bear, myoglobin has no trouble releasing its oxygen in that case, right? We've talked about cooperative binding, positive, negative. If you weren't able to picture the curve that Phil was talking about, definitely Google it, because whether it's with cooperative binding or whether it's with something else, it is very possible that you will see a sigmoidal curve on test day. Now, it's also kind of useful to, and hopefully you can tell us about this, Phil, it's kind of useful to know what affects, hemoglobin's ability to bind, because he kind of hinted at it, but there's quite a bit.
Right. So like, not only does a fetus have higher affinity than like adult hemoglobin, and like that sounds like it's just like a set concrete thing that like adult hemoglobin is always the same, but we can actually change our affinity for oxygen. We can like tweak those numbers, right? Because I know that I gave these numbers before, and there's a reason I gave those numbers, because I want to be able to kind of talk about this shift that we can go through. So in the earlier scenario, right, like 97% of our blood picked up oxygen. And then when it got to our muscles, 30% held on. So we only delivered blood in like 67%, or about 2/3 of our blood was actually delivering oxygen. Side note, that's one of the reasons that you can like hold your breath and the blood will go around like for a second cycle, and you might actually deposit some of that oxygen that you did before. And so if you just were sitting still and you just held your breath, you can hold your breath for a pretty long time. Definitely more than you can if you are sprinting. And at the end of the sprint, I say, hold your breath, right? Like that's, you got nothing, right? Like for that, you cannot hold your breath at the end of a sprint very well. But there's this shift that can occur, and it actually makes our blood lower affinity. And this tends to happen whenever we exercise. And like, that's kind of like the overall thing, like the actual cause of that we will talk about here in a second. But whenever we exercise, our affinity drops. And this is really counterintuitive to people at first, because what this means is all of a sudden when I'm exercising, instead of like 97% of my blood grabbing oxygen, only like 90% grabs oxygen. So I am worse at picking up oxygen in my lungs. Like in the time that I need more oxygen because I'm exercising, I'm picking up less. My blood is picking up less from the lungs. But then when it gets to the muscle tissue, because it's lower affinity, it's going to let go easier. And so before, where 30% held on, now it's going to be like only 10% holds on. And so if 90% of our hemoglobin picked up oxygen in the lungs and then 10% held onto it, that means all of a sudden 80% of our blood is delivering hemoglobin or delivering oxygen, compared to before where it was 67%. So this lowered affinity actually makes us better at delivering oxygen, because it makes us better at letting go of it. And this is something your body will do this shift whenever your blood gets really acidic from like exercising, because your blood gets more acidic when you exercise. And we'll talk about why here in a second. But I do just want to take a second. This shift is called the Bohr shift. And like, I just want to just take a quick moment and just appreciate the Bohr family, because there's a family of people, the Bohr family, who are like Bohr, that are like, their whole family was like geniuses. And so the guy who discovered this, like this Bohr shift, I think his name was Christian Bohr. I think I'm getting the Bohrs right, because there's a bunch of them. Like he had a son, Niels Bohr, who came up with the like Bohr model of an atom, and like he won a Nobel Prize. And then Niels Bohr's son, I think was like Bohr, and like he came up, like he was a nuclear physicist, and he also won a Nobel Prize. And so like the whole family is like, there's a Nobel Prize like every generation, and like everyone's geniuses and everyone's smart. And so it's just kind of an interesting thing, because you've almost assuredly heard of the Bohr effect. You're never going to get tested on this, but it's just super interesting. If you guys want to Google Niels Bohr, Christian Bohr, Bohr, because they all have like just a bunch of like really crazy stuff going on. But the Bohr shift itself, this lowering of affinity, is something that you will be tested on, right? And they expect you to be able to relate, to kind of like what's going on with this. So hope like it's very, very highly tested.
Yeah. And I think it might actually just be worth jumping into the acid-base component of it, because we've already talked about physics. We've talked about bio and biochem, but there's also, or biochem, but there's also a chem component and an acid-base component to this that's really helpful to understand, because how does the pH change come about?
Yeah. And so this is also a really, really highly tested thing. So first off, just kind of like taking one more bigger step back, like when we breathe, what do we breathe? We breathe in oxygen and we breathe out carbon dioxide. Why is that? Like, if you look at a cellular level, cells are like your muscle cells are bringing in oxygen for the electron transport chain, and they are kicking out CO2, because when we burn glucose in Krebs cycle, we produce carbon dioxide. And so that ends up dumped into our blood. So our cells at a cellular level are bringing in oxygen and kicking out CO2 that goes into our blood. And so that's why we have to breathe in oxygen in our mouth and breathe out CO2. Just as a side note, that's why when you lose weight, when you exercise and lose weight, like you lose that weight through breathing, actually. And this is like one of the just like coolest ideas, is that we break down glucose, we turn it into carbon dioxide and water, and we breathe it out. And so you're actually like, when you lose weight, it's because you breathed out more like mass than you breathed in, because mass is conserved. You breathe in O2, you breathe out CO2. And so like you're kicking out more stuff than you're breathing in. But the CO2 stuff in your blood, this is something that's like also insanely highly tested. I would say if there's one acid that you get tested on more than any other acid on the MCAT, it's carbonic acid.
Absolutely.
And like, at least for me, like I feel like I didn't hear about carbonic acid in any of my chemistry courses, but it's like incredibly important biologically. So CO2 will combine with water in your blood to create H2CO3, which is carbonic acid. And so whenever your cells are being really active and burning a lot of glucose and they're kicking out CO2 into your blood is becoming acidic, because that CO2 combines with water to make this acid. Just a side note, like outside this is also what happens in like carbonated beverages, right? When like the carbon dioxide in your beverage makes it more acidic. And like Coca-Cola, Pepsi, Dr. Pepper, like Sprite, all of those things are actually weakly acidic. But as the carbon dioxide leaves, like the bubbles leave, it loses that acidity, because what happens is the reaction just shifts in the other direction. That carbonic acid turns back into CO2 and then it escapes. And so that's why flat pop tastes different than pop that is like freshly carbonated and like that is very carbonated, is because it's actually like changing pH. And so like flat pop is not an acid, but carbonated pop is, which is super interesting. But the same thing is happening in our blood. And so the CO2 in our blood makes our blood more acidic. And that's what causes this Bohr shift. And so it's this change in pH, the acidity, like our body is exercising and it's making our blood more acidic because we're kicking out more CO2. It's also why exercise makes you lose weight, because you breathe out more CO2 when you're exercising. So you're dumping more CO2 into your blood, and that makes your blood more acidic, which makes your blood better at letting go of the hemoglobin, or letting go of the oxygen. And so that's why this Bohr shift allows us to deliver oxygen better when we're exercising. Super cool. Very pH oriented, very chemistry oriented. Maybe that's why I love it, because I'm a chem phys nerd at heart, but it's definitely pretty neat.
Yeah. And this, like you were saying, this initial acidity, because you have to leave soda out for a bit for it to truly go flat. But this is also, in addition to the sugar, why it's not the best for your teeth. But
because it's an acid. Yeah, exactly. Because it's an acid, right?
Yeah,
like,
exactly.
Like carbonated pop is acidic. And so like dumping an acid on your teeth helps like degrade it.
And so you'd have to leave it out quite a bit, and the sugar would still not be fantastic for it. But the couple of things, right? So absolutely, the chances of you, if you get a respiratory passage, a respiratory system-based passage, you will almost guaranteed see something about the bicarb buffer system in there, unless they've already tested it elsewhere, because it's such an easy test place to test, right? You have shifts in equilibrium. They could test, the difference between actually, they could also do some solubility if they really wanted to. But there's really a lot. It's a fantastic place for them to test you and to make sure that the connections between the different processes that occur, but also just the different systems that are involved in this. Now, we've talked a little bit about the affinity for oxygen. Something that we haven't talked about is what might cause your body to need to make more hemoglobin. And one thing is a shift in altitude. And so we've actually talked about this before, but you're going to hear us mention it again in case you haven't already watched that podcast or listened to that podcast, in which case you totally should go back and listen. But essentially, when you're at a higher altitude, you're going to have less oxygen, right? Because there's less pressure. So since there's less pressure in the atmosphere, you're going to have less pressure of oxygen. And so this smaller amount of oxygen available for the hemoglobin to bind is going to cause less hemoglobin to be bound to the oxygen. Because when you think about this hemoglobin dissociation curve, the amount of oxygen bound logically depends on the amount of oxygen available. And so when there's less oxygen in the air, because there's this lower pressure overall at this higher altitude, your body's going to say, okay, well, I still have the same oxygen demand. And chances are, if you're at a higher altitude, most of us, you're probably climbing a mountain or you're going up, and doing something active. And so you're also going to have a higher oxygen demand than if you're just sitting in your chair studying for the MCAT at home. And so your body's going to say, all right, we need some help here. And so it's actually going to cause the kidneys to release erythropoietin, there we go, and produce more red blood cells. And so you're going to have more hemoglobin available to bind to oxygen. And so that way you're still going to meet your oxygen demands despite having less oxygen available at this higher altitude. And that's why if you do it slowly and you give your body a chance to adjust, you're not going to pass out 5 minutes into your climb up Mount Kilimanjaro. But make sure you give your body a chance to adapt before you go for that benchmark.
Yeah, I definitely haven't climbed Kilimanjaro, but like recently, so my brother lives in Denver, and I think I've mentioned this a couple of times, but I recently did a trip to Denver, which is called the Mile High City because it's, way up in elevation. And we actually went hiking even higher up in elevation, up in like the 10,000 feet area. And like I flew from sea level, basically, where I'm at. And I went with my brother, and it was like startling, like how out of breath I got all the time, right? Like I'm like hiking like 30 feet and I'm like, okay, well, I need to sit and rest and breathe because my muscles weren't sore. It's just, I wasn't getting enough oxygen. And my brother was making fun of me because he's a brother and that's what brothers do. And he's like laughing and kind of like doing jumping jacks. He's like, what's wrong with you? Come on, like, let's go. And it's because he lived at elevation. And so his body has adapted. His body is not able to grab oxygen better than mine was, but he had just more blood, like more red blood cells. So when you go to an area that has less oxygen in the environment, your body will increase the number of red blood cells to just like make up for it by just like having more red blood cells. And so even if still like 30% aren't picking up oxygen, if you just have more red blood cells, you're going to deliver enough oxygen for your tissues. I was thinking about this, like I was wondering about people who like got COVID and then went to the mountains. Like that's real bad. That's real dangerous, right? Because already going to the mountains like makes it harder to get oxygen. And so like traveling with COVID, if you traveled into the mountains, like that could actually make you more likely to die and like give you more severe problems. Ironically, if my brother got COVID and then moved down to sea level while he had COVID, he would have a much easier time because like moving down here, he's got way more red blood cells and there's more oxygen down here. And so it's kind of an interesting thing. But there is also like, this is like one of my favorite fun facts. There's a group of people in, I think, Chile, who have a mutation. They live in the Andes Mountains where their specific hemoglobin is better at binding oxygen than normal human hemoglobin. And so these people at high elevation, they're better at grabbing oxygen from the environment. They're worse at depositing it in tissues, but overall, this is a benefit for them because they live at high elevations. And so this one group of people, this one like genetic enclave, like anytime there's any sort of like marathons that are high up at elevation, these people always win them. And like, because there's like some marathon runners that are like in this group, and like they always kill all of the marathon runners at high elevation stuff. Now at low elevation, they actually are at a little bit of a disadvantage because their blood is less good at letting go of oxygen. And so in oxygen rich environments, it's not really a benefit to them, but in oxygen poor environments, they're better at delivering oxygen. And it's just such a super interesting thing because it's like this mutation that has occurred in this one population that actually caused a bunch of benefit there.
Yeah. And really quickly, this is a scenario where, like for the most part, we've been talking about oxygen availability, but if you think about someone who is constantly needing more oxygen, like someone who is pregnant, the body will also adapt in that case too. And it's really interesting. The amount of like people who are pregnant, their body will produce a lot more red blood cells and hemoglobin, right? But they actually look anemic because on paper, in terms of percentage, because their blood volume also has to expand and increase in order to accommodate all this extra hemoglobin so their blood doesn't turn into sludge. And so we call it like physiologic anemia of pregnancy. But essentially, the same way that there's, an increase in production if there is a decrease in availability, you're also going to have an increase in production if there's an increase in demand. So your body is listening to supply and demand the same way any of your economics friends are paying attention to supply and demand.
Yeah. I love that, like listening and kind of paying attention, because I know we've talked about how like carbon dioxide in your blood makes your blood more acidic, but there's also your body is listening to how like acidic your blood is. So if your blood is too acidic, note that getting rid of carbon dioxide will make it less acidic, just like a soda when it goes flat, right? And so when your blood is too acidic, your body will naturally increase your breathing rate. And so you'll start to hyperventilate. You'll ventilate faster. And so your breathing rate will go up and you'll go when your blood is more acidic instead of just breathing normally. And that's a super cool thing. Like it is actually changing the pH of your body by changing your breathing rate. Likewise, if your blood is too alkaline, then you kind of want to keep the carbon dioxide in. And so people who have alkaline blood, they will breathe less often. And so that'll hold the carbon dioxide in. Your cells are constantly making carbon dioxide and dumping into the blood. So if you just hold it in a little bit more, your blood is more acidic and might fix that pH shift. And so this like one of the coolest things is that your body is regulating its own pH via changing your breathing rate. And that's like a super interesting thing. That's also one of the reasons that you breathe more often when you are exercising, because when you're exercising, you dump more carbon dioxide into your blood, which makes your blood too acidic, and your body is trying to fix that by blowing out that CO2. It's also pulling in more oxygen, which is coincidentally what you also need. And so it's just kind of an interesting thing. I will say that there are sometimes drugs and medications, especially in like IVs, that can make your pH change. Or you might have like an issue with your kidneys that might affect and change your pH. And so there are times where like somebody getting a drug might make their blood more acidic or more basic, and that will change their respiratory rate. And so if I give somebody a drug that is like a weak acid into their bloodstream, their body is going to breathe faster to try to fix the pH stuff going on. And so it's just kind of an interesting thing that a drug may change the breathing rate because it's changing the pH, which is like a super cool, interesting idea. Yeah.
Yeah. And I know folks are probably at least one person is thinking, okay, y'all are nerding out again. I'm probably not going to need this, but you will.
Yeah.
You will have to take samples of your patient's blood from their arteries, and that's going to give you the levels of carbon dioxide. It's going to give you the levels of oxygen and bicarbonate. And you're going to have to figure out, okay, is their problem primarily a metabolic problem and their lungs are helping compensate? Or is it primarily a respiratory problem and they've been at this for a while and their body is metabolically compensating? And so you will see this again in med school, in your future career as a physician. So yes, we enjoy nerding out, but it's also going to be helpful.
Yeah. I mean, not only that, like it's going to be on the MCAT, like this blood buffer bicarbonate system, which is what it's called. because when carbonic acid loses a hydrogen, it becomes bicarbonate. So this blood buffer bicarbonate system and regulating your pH is insanely high yield for the MCAT. Yep. And so this isn't just us, like, okay, the Bohr family, you don't need to know about Niels and Christian Bohr, but like this buffer system and like how your body regulates its pH, it's very high yield. And you want to make 100%. Sure that I think that like carbonic acid, as I mentioned, you're more likely to see that show up on an exam than you are hydrochloric acid. Like carbonic acid is just insanely high yield.
Yeah, it's essentially the intersection, because we didn't talk about this, but carbonic anhydrase is the enzyme that's involved in this. So you can get tested on enzymes. This is Chem Phys. There's, they could ask you some orgo adjacent questions, respiratory system, so bio. There's really a lot that's going on here just with this one equation. So I would actually sit down, and this is something that I did when I was studying. I would sit down and write out the bicarb buffer system and then practice. Okay. And actually, Le Chatelier's principle applies here too. So I would sit down, I would say, okay, if I am hypoventilating, right, what's happening? In what direction is there going to be a shift? If I'm hyperventilating, what's going to happen, right? If, and then play with the idea of, okay, if there's, if the pH is lower, how is the body going to respond, et cetera? And make sure that you can do that. It's good practice, not just for cementing the bicarb buffer system, but also just for chemistry practice in general, and making sure that you know how systems are going to respond to pressures. In this case, pressures being not a literal partial pressure, although it can, but just like a disturbance.
Yeah. I also think it's really interesting to just understand. So you can personally change the pH of your blood by holding your breath or by breathing too fast. Right? Like hyperventilating or hypoventilating. And this is something that like, there's lots of things that control your respiration rate. One is like the pH stuff. One is oxygen need. One is also just sympathetic, parasympathetic stuff. Like when somebody goes into fight or flight, very often their body thinks, okay, we're about to run. We're going to need a bunch of oxygen. Let's increase breathing rate. But like, if the reason your fight or flight is kicking off is because you're having a panic attack on an airplane, because you're worried that like you're having a panic attack, which is about flying, right? In that case, you don't actually need more oxygen, right? But your sympathetic system kicking in is going to make you hyperventilate. It's going to make you like breathe too fast. And like, this is where like why people breathe fast and panic attacks is because of sympathetic activation. And think about like, what is that going to do to our pH? Right? We're breathing out all this CO2 because we're ventilating too fast. That's going to make our blood more alkaline because the carbon dioxide makes it more acidic. And so there's some really interesting studies that show that blood pH can also change the way that you see and feel, like see the world, not like see physically, but like see the world and interpret the world around you. And so when your blood is more alkaline, you actually tend to like be more nervous and more like having like a weird kind of like, you don't feel good. A lot of times if your blood gets a little bit acidic, you actually feel better and calmer and more relaxed. And so there's this really interesting positive feedback loop that person's having a panic attack, making them hyperventilate, which makes them more nervous and more panicky, which makes them hyperventilate more, which makes them even more nervous and panicky, which makes them hyperventilate even more. And so it's this positive feedback loop where it just keeps getting worse and worse. And so this is why one of the things that we recommend to patients is to like breathe into a bag if you're hyperventilating and having a panic attack. And it's not that the bag's doing anything like specifically other than just making it so that when we breathe out that carbon dioxide, we're breathing it back in. And so we're making our blood more acidic, which tends to have a little bit of a calming effect overall. And so like hyperventilating into a bag will like kind of counter that pH change in your body, which is super interesting. I also like to just sometimes think about like meditation, right? Like sitting and like meditating feels different than sitting and watching Netflix on the couch. At the level of like muscle activity, there's really not much difference between those two. But when people meditate very often, they'll do like deep breathing exercises or like doing yoga or things like that. And they slow their breathing purposefully. Note that if you sit and you just breathe slowly, it tends to make your blood more acidic, which is actually also what happens when you exercise. And so that's why a lot of times they're like doing simple, slow, deep breathing exercises can make you kind of feel like you do after exercise, like not in terms of sore muscles, but in terms of just, I feel good, I feel calm and things like that. I just feel good. I always talk about this with my students because I encourage students like during their exams, like when you're like, you finish like 2 or 3 passages, just like take a deep breath for a second and just hold it. That kind of helps you kind of like feel good and feel calm and just kind of relax a little bit and stay in the zone instead of getting panicky and freaked out, which we don't want to happen on the day of the test. So you can kind of like stop and think, like hold your breath and think about how it's making your blood more acidic for a moment. At least that's what I did when I was taking my MCAT.
Thing to say.
Yeah, I'm just slightly more acidic. I feel better. So that's also an interesting thing. Is like understanding like this like pH stuff could have psychological effects, which honestly, that would be a great psych passage, talking about the effects on emotion and panic attacks. And they could go into stuff with like operant and classical conditioning into that as well. But I think that would be an interesting passage overall. Because remember, biology also shows up in the psych section of the test.
Mm-hmm. Yeah. So we could talk about this forever.
Mm-hmm.
We won't, for your sake, but there are actually a lot of different things that can go wrong in the lungs, and we won't spend a bunch of time talking about them because you're not going to get tested on them. But everything from disorders where your body is producing a lot of mucus and you lose lung parenchyma and tissue, and now there's more space and less lung, right? Something like COPD, situations where, in something like cystic fibrosis, there's something wrong with the electrolyte transport, right? And sodium and chlorine transport. And so, oh snap, and water, right? And so, oh snap, now you have really thick mucus in your lungs and you're more prone to infections. You can aspirate something and it can go down your lungs instead of into your stomach. And that's really problematic.
Yeah.
Or people, who have really bad acid reflux and it irritates their throat, right? And their lungs because it's going down the wrong pipe. Or even, based, and this is actually really fun. It took me a while to learn this, but you can figure out where in kind of the respiratory system someone's problem is based on how they're breathing. If the noise, and the stridor is whether it's happening when they're taking a breath in or whether they're taking a breath out, you can figure out where the problem is. And so there's so much here that's really just interesting. And I would encourage you guys to take a look at it. And actually something that hopefully you guys have picked up on is that it's easier to remember MCAT topics and information if you find it interesting. And so if there's a topic that you're just like, I hate this, I can't remember it, and I know it's high yield, oh my gosh, what am I going to do? Go look up something fun about it. And you're more likely to remember because now you're like, oh yeah, there's actually something really cool that's related to this.
Yeah.
So
not only that, I also feel like, honestly, like COPD, like while they're not going to test and expect you to know about COPD,
could be a passage.
You could see a passage on it because the MCAT loves throwing passages at you where they know this is a little bit
uncomfortable
past what you know, but they want to see if you can apply what you know. And so I've also seen passages on like thalassemias. Right. Like, which is when there's problems with the hemoglobin specifically. And they're like, depending on the hemoglobin, like which one's being affected, like this may be something that only affects fetuses, or this is only affecting adults, or maybe it affects both, depending on what hemoglobin subunit is actually messed up. And then also talking about like pH and like all of this stuff is something that is absolutely testable in the context of a passage. And you got to have a really good, deep understanding of how this stuff works at like a big picture level, in order to apply it to all of these scenarios, right?
Exactly.
And so like what's going to happen to the pH of somebody who goes up to a high altitude? They're not getting enough oxygen, so they breathe faster. Like what's that going to do to their pH, right? And what's going to be going on with that? And it's like, that's absolutely a question that you can see on test day. You can see all day long for sure.
Yeah. So now you can take a deep breath in and deep breath out and wrap up this podcast with us. But as always, check out the Jack Westin website for more information to connect with our free academic advisors, or maybe just you want to head over to our outline and read more on some of these topics. Head on over, so many resources, get connected, and we will see you next time.